pregnancy is an interesting time. I always think it's very funny that people consider it physiologic because so many odd things start happening with your body. One of the things that can happen during pregnancy, though, is the development of blood clots.
Yes.
So how do you manage a pregnant patient who has a blood clot?
Well, I think it's important to distinguish from the crowd at least what type of blood clot they have. A blood clot in one of the deeper muscular veins, that means one of the veins that are embedded within the muscle fibers, is far more concerning than a clot that's located in a varicosity that might have formed during pregnancy, what we call a superficial thrombophlebitis. If patients have a blood clot in the deeper veins, they have to be anticoagulated. And obviously, the medications that we use to anticoagulate patients in general cannot necessarily be used in all patients when they're pregnant because of the pregnancy and the possible risks or the unknown risks to the fetus. So the standard is some sort of injectable heparin, which has been proven to be relatively safe to the fetus, but does relegate the pregnant patient to injecting themselves on a regular basis with some sort of heparin-type medication to keep their blood thinned. There are new medications out on the market that are oral, that are similar to heparin, but I do not believe they have been investigated for use during pregnancy.
Okay.
Now, for those patients who have a superficial blood clot, that becomes a question about what to do when they're pregnant. There are some who will anticoagulate them fully, and there are some who will treat them more conservatively with the use of compression stockings, knowing that this blood clot is unlikely to move from its location or to cause a more dangerous problem, such as a pulmonary embolus. That's a blood clot going to the lung. And just recently we had a patient who unfortunately lost the pregnancy and had some bleeding, and it became impossible for me to anticoagulate her, and we had to treat her conservatively with some compression stockings and the like. So certainly pregnancy creates some roadblocks to the typical management that we usually provide for our patients.
There's been a change in the frequency of hysterectomies. I think there are fewer hysterectomies being done now. Do you think that has affected the number of people you see with pelvic varicosities?
That's an excellent question. I don't know the answer to that question, whether the decrease in hysterectomies has reduced the incidence or increased the incidence for that matter.
Yeah.
I can say that many of the patients I see have not had hysterectomies and have these varicosities. Some of the patients that I see with pelvic venous problems have had hysterectomies to try to treat it without success.
Okay.
So I don't think there is a relationship. I think that when a hysterectomy is done, some of the venous branches are closed off or ligated, and they may be closed off in a way that makes things worse, because certainly I've seen people get worse.
Really, after hysterectomy?
Yeah.
Well, that's interesting.
And it's very important to understand where the veins are coming from and going to kind of treat what needs to be treated. And I haven't found hysterectomy to be a very effective tool in treating pelvic venous problems at all.
That's a really good thing to know. So those patients you would investigate by doing an X-ray study.
Correct.
Is that right?
Yeah, MRIs, which are not really X-rays, if people are concerned about radiation exposure, are a very good test to look at the pelvis and to see what venous abnormalities might be present in the pelvis. And we often offer that to our patients as a first-line study to evaluate what's going on in the pelvis. Generally, we do that after we've done an ultrasound, suggesting that things are coming from the pelvis, but we can only really see the upper legs when we do that. And that's usually how we approach that.
Okay, so first you would do an ultrasound, and then you might get an MRI, and then you would go on to your specialized X-ray studies.
But it's important to note that if it's the type of patient who has some veins in the upper leg, in the vaginal area, that if they're not that severely symptomatic, we can treat them just by injections alone. I reserve this kind of more expensive and more investigative treatment for patients who are not getting better and have a lot of symptoms after they've failed that type of therapy.
All right, so that's not something that you use for every single patient who walks in your office. Oh, that's very interesting.
I tell them when I make the diagnosis or I have some suggestion that they have a pelvic problem with the ultrasound that was done, I tell them, I give them kind of a scenario of what we're going to do. We're going to fix this problem, and if it doesn't go away, this is where these are the things that we may have to do to address it.
So then it's pretty reasonable for a patient to start with a local phlebotomist.
Yes.
And if they're not getting better, I bet that you see people from all over the country or all over the world.
Well, I see a fair number of people from different places, yeah.
Yeah, because what you do is fairly specialized, I think.
Yeah.
But
it is important that most of these patients can be treated by the average phlebologist just by injecting some of the veins in the upper portion of the leg. We don't have to start pulling out very expensive, or high-cost investigative studies. Just treat them, and then if they don't get better or they have recurrent symptoms or recurrent veins, then it's time to start looking deeper into the problem.
You've mentioned compression stockings several times, and as you know, that's one of my favorite ways of treating patients. I'm a big stocking proponent. One of my pet peeves is that the physician, let's say an OBGYN doctor, will tell their patient very wisely to go out and get some support hose. And then patients will go to a maternity store or a department store and buy these support hose that don't really do much. Can you talk a little bit about where people should go and what kind of stockings we're really interested in?
Well, I cannot tell you how many times that we have sent patients to the store to get stockings, even with a prescription in hand, which always amazes me, and they'll still come home with the wrong stocking, either the wrong length or the wrong pressure or the wrong something. And so it is a confusing problem because we do advise our patients to either get them in the office, and we never carried stockings until we encountered this problem over and over again. The patients would show up with the wrong stockings. So we do carry a limited supply, and they can get them there in the office. But I often advocate going on the internet and giving them information, giving them a prescription, telling them what to look for, even giving them some websites to go to where they can save some money and get the stockings that they need. But it is a tremendous problem. I mean, I don't know how to. I always direct them towards surgical supply stores and not the local pharmacy.
Right.
But even when they go to those stores, sometimes they get fitted incorrectly or they just get the wrong length. I can't tell you how many times I've checked off thigh high and they come home with a knee high. So I just don't understand that, but it happens all the time. Maybe, does it happen to your patients as well?
We carry stockings in our office, so we actually fit them. What I try to stress with my patients is it's okay to go to a pharmacy, but the one word that they should look for on the package is the word graduated, so that it's tighter at the bottom,
right,
looser as it goes up the leg, and that's really the most important thing to find. You mentioned the idea of knee highs versus thigh highs versus pantyhose. When do you decide which one to use?
Very good question. I mean, there are two things that have to be decided. One is, what are you trying to do with your stockings? If you're trying to take care of a patient's discomfort and maybe some of the venous congestion or pressure problems in their legs, then very often you want to choose something that they're likely to wear on a regular basis.
Good idea, right.
Because if you give them something that they're not going to wear, then it's like giving them nothing. Right. So don't bother. So knee highs serve that function very beautifully. So if a patient has it. Now, there are patients who have upper thigh varicosities, and putting on a knee-high stocking, or have varicosities right at the junction where the stocking ends, and sometimes that can cause a phlebitis or cause pain to the patients. So those patients really need to be in a thigh-high stocking. Another thing to consider is a patient's leg shape. Very often patients who have kind of a triangular leg shape where the thigh is much bigger than the calf, it's very hard to get them fitted right, and fitting them correctly so the stocking doesn't slide down is a big issue. And sometimes those patients have to go into pantyhose because there's really no other garment that will stay in place. So it's very individualized, and you kind of have to talk to the patient, kind of see what they're willing to do, and also look at their legs and see what you're trying to accomplish, whether you're trying to compress their calf to prevent ongoing venous problems, or you're trying to compress some varicosities to prevent them from getting a superficial blood clot. So all of these factors go into play. What I did want to mention, kind of slightly not off this topic, but very often patients will say to me, oh, I always wear compression stockings. And then when you ask them what kind of compression stockings, and you say, well, what color? They're these white stockings, which are the typical TED stockings that the hospital gives out to all the patients. And the patients say, well, if they got it from the hospital, it's got to be good. And those things, as you know, don't have any pressure at all and do almost nothing.
Right. Those stockings are really meant for patients who are in bed.
Right, lying down.
Right. That's what they're made for.
Right.
So they're good for when patients are in bed, but once they're upright, they need a stronger, graduated compression stocking. I completely agree with you.
And some of the gynecologists will give them TED stockings or prescribe TED stockings.
Right.
And so it really does nothing for them. So the patient will come and say, I've worn compression stockings. And then you really have to investigate what they've worn and what type of stocking they have.
Absolutely. In terms of convincing or encouraging our patients to wear stockings, what do you find helpful?
Well, education is always helpful, telling them what it's going to do for them. And I find that once you convince them to wear it, they'll always tell you that they feel better. There's no question that when they finally get into a good fitted stocking that doesn't roll down on them, they will tell you that they're more comfortable. And I think it's just getting them to that point, and then also getting them to a point where they can put it on without struggling with it. Very often, patients don't know how to put on the stockings, and as a consequence, they can't get them on, and they just get frustrated and won't wear them. So it's important to educate them on how to put them on. And size them correctly.
The other thing that I find is that when we start talking about stockings to people, they have a really negative reaction because they think they're going to be ugly and everyone will know that they're wearing compression stockings. So I always wear compression stockings in my office, and I ask my staff to wear compression stockings as well so that our patients can see that we're wearing stockings and they didn't even know that we had them on.
And they make all sorts of stockings now that are certainly as attractive as many of the regular stockings that they sell, in the drugstores. So there are many options that people have. Men can wear black stockings that look like black socks, and women can wear relatively sheer stockings that don't look like the old thing they may have seen their grandmother in.
Right. Very good point. You were talking a minute ago about how the length really depends on what we're trying to compress. So if someone has a painful varicose vein in their thigh, you definitely need to keep compression on in the thigh. And sometimes I'll actually put an extra light wrap to put a little extra compression around there. The other thing that we used to do is when people would have painful varicose veins in their vulvar region around their vagina, we would have them roll up a sanitary napkin like a Kotex and put it between their stocking and the vulva to give a little extra compression.
Right.
Have you ever tried anything like that?
Well, I haven't tried that, but there is something called a V supporter, which is out there. It's not carried in many stores, but you can get it online, and it does pretty much what you've described. It's kind of an undergarment that pulls up in that area and provides a little bit of compression to that area. And certainly adding some sort of cotton gauze or something like that to add additional compression is always a good thing to do. And we were talking earlier about some of the pregnant patients, and that's one of the things that I do recommend and do prescribe for the pregnant patients who are in that position where there's not much you can do other than that.
A V supporter.
Yeah.
So people can go online and just put into Google.
Pretty much.
You can put anything into Google these days.
I think you'll find it.
V supporter.
Yeah.
Interesting.
Yeah.
All right.
Yeah. I think you'll find it there. I know. I know more about underwear than I should. I know.
Okay, I think we're... Is there anything else that we should talk about?
Can you do a little wrap up? Thank you so much.
Okay. All right. Mel, I really want to thank you for having this discussion with me.
Thank you for having me.
It's really a pleasure to talk with you. You have so much experience and so much knowledge that very few phlebologists really have. And this is a group of patients who, as you mentioned, tends to get passed around to doctor after doctor after doctor. So I really appreciate your taking the time to share
My
your
pleasure.
information. Thank you.